Welcome friends. I am Dr. Baldev Prajapati, Professor Emeritus and Director, Medical Education and Research, Baldev Medical College and Hospital Kadi, located in North Gujarat. These are my 4 books published in the field of pediatrics, particularly on procedures, signs and symptoms, clinical pediatrics, and very specific on OSCE, spotters, and viva. Today I am going to talk to you regarding difficulty in breathing or dyspnea, very important and common condition in our pediatric practice. How we define the dyspnea? Dyspnea is used for the difficulty, uncomfortable or labored breathing by the parents. And it is often described as shortness of breath or air hungers. It is physiological on exertion, but sudden, persistent or progressive dyspnea, even at rest, often indicates an underlying very important cardiovascular or respiratory condition which we should not miss. How we grade the dyspnea? This is very important. Grade 1 means dyspnea with climbing the stairs or running for a short distance. Grade 2 dyspnea while performing even the routine activities. Grade 3 dyspnea following even the light activity like going to bathroom or from one room to another. And dyspnea even at rest is grade 4. And grade 5 the orthopnea. Orthopnea means breathlessness in recumbent position, and person gets relief by sitting or standing and even sometimes going to the window and taking the fresh air. What are the signs of increased work of breathing in our practice which one should be clear? The first sign of increased work of the breathing is the tachypnea. Then there are the various chest retractions, depends upon the pathology, which may be suprasternal, subcostal, intercostal. Even you can see the use of accessory muscles like sternocleidomastoid muscle. There may be with even more severity, flaring of Allinese, head bobbing. Even abnormal sounds are very important like stridor, wheezing and grunting. Type of breathing is very important, and altered sensorium and cyanosis is always indicating severity of increased work of breathing. Friends, how we define the tachypnea? Before that, one important message which I want to convey to you, that please count the respiratory rate for complete 1 minute, complete 60 seconds. And very importantly, young children, that respiratory rate should be counted when the child is quiet. That means not crying or child is sleeping. This is very important because it provides you very reliable information. And the next step is the cutoff rates of respiration rate for tachypnea at different ages. 0 to 2 months more than 60 respiration rate, that means tachypnea. 2 months to 1 year, more than 50 respiration rate per minute. 1 to 5 years, it is 40, and more than 5 years, more than 30 respiration rate indicates it is tachypnea. Various chest retraction, the presence of chest retractions or site of retractions indicates sometimes at site of pathology and even the severity of the disease. So, very important clue for the clinician. Subcostal indrawing, that means increased work of diaphragm. Very commonly we pediatricians in a case of bronchiolitis. Intercostal indrawing, that means decreased compliance of lung parenchyma, commonly we see in a case of pneumonia or congestive heart failure. Suprasternal indrawing, that means involvement of upper airway, that is the upper airway obstruction, maybe in a case of vascular ring, diphtheria or acute laryngotracheal bronchitis. Please remember that with the increased severity of disease, chest retractions may develop at multiple sites. But very important for the clinician to decide the pathology or reason cause for the increased work of the breathing, that site of retraction is the onset of the disease, and that helps a lot. So, it is to be defined very appropriately. Some abnormal chest sounds, if you see, nasal snuffle, all of us see, very commonly it is nasal secretions or even the noisy nasal breathing. And it is common in the infants in the first 3 months of life, but many a times since birth, if it is, may be the feature of congenital syphilis. Snoring in a case of hypertrophy adenoids and sometimes even obesity. Rattling sound, what we say, that is throaty gurgling sounds commonly heard in a case of laryngomalacia. Stridor, that is extrathoracic airway obstruction, maybe in a case of vascular ring or even the diphtheria. Wheeze, that is the intrathoracic airway obstruction in a case of bronchiolitis or bronchial asthma. Rales, what we say, that is small crackling, bubbling sounds heard in the lungs, particularly during inspiration, very classically bronchiolitis. And grunt, very indicate lung parenchymal disease. Here it is a forceful expiration against partial closed epiglottis. It indicates the, I will say, gravity of the problem, severity of the condition, maybe in a case of hyaline membrane disease or even severe pneumonia in older children. Abnormal breathing, prolonged inspiration, upper airway obstruction, prolonged expiration like bronchial asthma, rapid breathing without retractions and sounds. Please remember that is metabolic acidosis. Maybe the condition like diabetic ketoacidosis, inborn error of metabolism, chronic kidney disease, or sometimes even degenerative renal acidosis. Rapid breathing with minimal retractions in a case of CCM. Rapid shallow breathing indicates the pleurisy. Apneustic breathing, that means CNS problem, and presence of flaring of alienasia and head bobbing indicate the severity of respiratory disease, may be the case of impending pulmonary failure. Respiratory signs and the site of lesion can be defined by the good observation of the clinician. Tachypnea is not much problem, but retraction, yes, and stridor, that means is the extrathoracic problem. Tachypnea is there, retractions are there, wheezing is there, that is the intrathoracic, and with the increased severity there may be the stridor also. Tachypnea is a very important, I will say, feature of lung parenchymal problem. Retractions will be there with the severity. Wheeze, yes, and presence of grunt indicates severity or gravity of the problem. Please, friend, remember, altered sensorium and cyanosis are signs of severe hypoxemia or impending respiratory failure, which clinicians should keep in mind. Thank you very much. Friends, before I end, I request you to subscribe over this channel, and if you subscribe every time, you will get some new informations very useful in the exams and in the daily practice. Thank you. Thanks a lot.